Welcome to today's webinar. We appreciate everyone taking the time to join us today. We are excited to welcome our presenters, Dr. Ray Fowler and Dr. Melanie Littman. We will be turning the webinar over to Dr. Fowler and Dr. Littman, but first we want to share some webinar tips. NAMT would like to recognize our sponsor for today's webinar. On behalf of NAMT, we extend a warm thank you to Wheeled Coach. We thank Wheeled Coach for their continued support in advancing the EMS profession and caring for our nation's EMTs and paramedics. Please be sure to download and review their sponsored handout. It is NAMT's pleasure to introduce today's presenters, Dr. Ray Fowler and Dr. Melanie Littman. Dr. Ray Fowler has been an EMS physician and a leading educator, medical supervisor, and political advocate for more than 4 decades. He is the James N. Atkins, MD, Distinguished Professor of Emergency Medical Services, and the Chief of the Division of EMS, Department of Emergency Medicine, University of Texas, Southwestern Medical Center. He was a co-founder and the second elected president of the National Association of EMS Physicians. In addition to his many other accomplishments, he was a co-founder and senior faculty member of the National EMS Medical Director course. Our other presenter is Dr. Melanie Littman. Dr. Littman is an associate professor of emergency medicine at Brown University's Alpert Medical School. Since completing her emergency medicine residency at Yale, she has sustained a particular interest in caring for patients with psychiatric emergencies and substance use disorders in the emergency department in the pre-hospital setting. She also has a long-standing interest in teaching and mentoring students. Welcome, Dr. Fowler and Dr. Littman. I now turn the presentation over to you, Dr. Fowler.
Well, thank you so much. And Melanie, say hello to our crowd.
Good to be here.
Good to be with all of you today. This is an extraordinary time in the history of medicine. I'm sitting in my hometown here in Douglasville, Georgia, just west of Atlanta, where I came to practice medicine over 40 years ago. And we had this astonishing epidemic called HIV that rolled out 40 years ago that has taken now almost 50 million lives around the world. An extraordinary epidemic. And I show you this slide just to get started to say that it appears that the good news is that maybe COVID is about to roll off and that life will begin to get back somewhat to normal. Though I hope and I suspect that virtual education, like Melanie and I are doing today, will be a way of the future because we can reach so many people so quickly. Melanie and I today want to talk to you about electrocardiography. I don't know, kid is a compliment coming from an old man. And I don't know how much kids really enjoy history, but history is where we came from. And in the setting of where the electrocardiogram came from, there was this French physiologist named Augustus Waller who was working in London back in the 1880s. And he got a hold of this device that you see right here called a capillary electrometer. And actually it was a Littman with only one end, capillary electrometer. Melanie, I don't think that's any relation of yours, I don't suppose.
It's probably remote. It is actually 2 ends, to be honest.
Oh, that is 2 ends. Yes, you're right, of course. And so Augustus Waller actually was able to record some sort of electrical thing that was correlated with the pulse on this dog that you see right here. And the dog's name was Jimmy. This is actually a true story. And Waller used to do demonstrations of this electrocardiogram on his dog, Jimmy. And here is actually a sample of the initial electrocardiogram. This was done in humans. And Waller would do demonstrations of this device, the Littman, the Littman electrometer. And he was doing one in Croatia when this guy named Willem Einthoven, who was a Dutch physiologist working for an ophthalmologist, who was a genius of a guy. This is when Maxwell was doing his work on describing the laws of electromagnetism. This is very important. Maxwell showed that electricity and magnetism and light were all the same thing, just different sides of the equation. And so here is Einthoven, a very, very bright guy working in relation with 24 other folks in Vienna, and he was working for an ophthalmologist, and he was thinking light, electricity, and then he sees this dog in Croatia standing in several pails of saline, creating an electrical stimulus. And Einthoven went, as they said back in those days, dude. Isn't that interesting? So Einthoven got hold of one of them capillary electrometers, the Lippmann electrometer, and then he improved it. And he ultimately created what you see here, which is a string galvanometer, which became a medical school device all the way up into the 1920s and 1930s. Einthoven went on to describe all that we know about normal electrocardiography, and I'll tell you more about that in a moment. Described all the waves, I'll tell you about that in a second. And he did this original landmark work and received the 1924 Nobel Prize for creating the electrocardiogram. So ladies and gentlemen, when you look at an ECG, when you hold it in your hands in the field, you're holding a Nobel Prize from almost a century ago. That what was done with an electrocardiogram, the ECG, EKG, same thing, was so important that it was a landmark step in the history. And indeed, here is his lecture. There's a wonderful website you may want to go to called nobelprize.org, in which they list the lectures done by every single Nobel Prize winner in history. And Einthoven went on to show in part this electrocardiogram, in which he had named the waves here, which we'll come to in just a moment. So this is a part of history. And indeed, from 1920, here is the Cambridge electrocardiogram, the string galvanometer, which led to the electrocardiogram, which became a medical school device for many years, as it then made its way out into clinical practice. Isn't it interesting, ladies and gentlemen, that you have on your monitors and defibrillators in your rigs something which relates directly back to the history of medicine? It was recognized as so important that it was given a Nobel Prize, and you have it in your hand when you run every single patient. Einthoven was a genius. Einthoven knew clearly from Waller's work that there had to be standardization done so that the heart, which has its own fixed anatomical features, could be described electrically. And so Einthoven came up with the Einthoven leads. One's on the top, two's on the right, three's on the left, fight, fight, fight. I made that up. One's on the top, positive here. Two is on the right, down below, positive down below. Three is on the left, positive down below. These are the Einthoven leads.
I would say think of those like vectors, right? Just to make it a little more clear. Think of those as like electrical vectors to make it more clear in your mind.
Yeah, absolutely. What Melanie was saying is think of it as you're measuring the vector, which is the direction of the flow of electricity. And that's great, Melanie. We'll talk about that. Einthoven went on to describe what he saw. And he saw this first little bump, followed by this bigger bump, followed by another bump. And so Einthoven went to the alphabet and said, given the fact that there may be a bump discovered before the first little bump, and there may be a bump discovered after the first little bump, what area of the alphabet is not yet taken up by consecutive letters? And he came to PQRST. Einthoven named the P wave, the QRS complex, and the T wave. He anticipated that there might one day, there hasn't been, but there might one day be a wave show up before the P wave. And he anticipated that there might be a wave show up after the T wave, and there has been, as you may know, called the U wave. So P, Q, R, S, T, and U are the leads that were named. In 1942, one of the world famous electrocardiographers named Goldberger said that in the frontal plane, we need additional leads to be able to more accurately give a figure to the actual measurement of axis. And so Goldberger came up with the augmented voltage leads, AVR, AVL, AVF. AV stands for augmented voltage. It just so happens that leads 1, 2, and 3 are bipolar leads, which measures the plus to the minus in the lead. And the augmented voltage leads, if you know anything about electricity, are measured relative to ground. It doesn't matter we treat them the same way. Notice that leads 2, 3, and AVF are positive down low, under the heart, inferior to the heart, below the heart. And that leads 1 and AVL are positive beside the heart, to the left lateral part of the heart. Now, I want to show you that the heart doesn't sit in the chest this way. This is the right ventricle. This is the left ventricle. The heart sits in the chest this way and lies down. Therefore, the right ventricle is in front and the left ventricle is pretty much in back. And so, recognizing that, in 1938, the American Heart Association and the Cardiac Society of Great Britain said, we need leads that will measure current flow from anterior to posterior, and thus came up with the anterior leads, V1, V2, V3, V4, V5, and V6. Notice that on this slide, I add in the fact that AVR is also an anterior lead. Let me repeat that. AVR is an anterior lead also. Notice that AVR and V1 are virtually side by side. Therefore, AVR and V1 are virtually identical on the electrocardiogram, and they give you as important an information as regards especially anterior wall myocardial infarction. Melanie, any comments so far before we move into interpretation?
Let's start getting into interpretation.
All right, so now, ladies and gentlemen, it's very important that you understand that when you look at your electrocardiogram, you're looking at two things. You're looking at a rhythm strip and you are looking at the 12 lead. They overlap, but they have some separate features. I use the Dale-Dubin method of interpreting the 12 lead, which is rate and rhythm followed by axis, hypertrophy, and infarction. I use this method that I've sort of stolen from Amal Mattu of the University of Baltimore at Maryland.
One extra piece, I like to think about the intervals too.
Of course. So let's talk about them. You mean on the 12 lead, Melanie?
Yeah.
Yes, of course. And then interpreting the rhythm strip, rate and rhythm, followed by a top to bottom, from the atria to the ventricles, analysis of the heart. P, the depolarization of the atria, the intervals, the PR interval, the QRS, the QT, the ST segment, the T wave, the U wave, and assessment. Now let me ask you a question. If you were to take the first letters RR, PIST, TUA, what would those be? It would be RR pistua. That really sounds stupid, but that is the order of the interpretation of the rhythm strip. All of you right now, this is a high order learning. Repeat after me. RR pistua. Say it. Good, I heard you all. Now we're going to do them together. RRPIS. I say it together. RRPISTTUA. I will never waste your time in an educational get-together. One of the critical things on here is intervals. Is that if you don't think about the intervals and think about all three, the PR, the QRS, and the QT, if you don't think about it, you won't think about it, and therefore you'll miss the fact that someone who is overdosed on some medication, let's say on a medication related to mental illness, for example, that in fact they might have a prolonged QT interval. If you don't look for it, you won't see it. Melanie, any comments about that so far? You mentioned about intervals.
No, I think we're good. Guys, don't be afraid to post comments, and I will keep an eye out for them, and I'll interject and make sure all your questions get answered along the way. You know, like, for example, like if you said, maybe you see a long QT on their EKG, probably they shouldn't be getting more QT prolonging medication. So maybe that's somebody I wouldn't give Zofran to. Zofran will prolong your QTC, probably not smart if they've already got a long QT. And of course, we won't get into the details, but don't, like the QTC is actually, the normal range is slightly different in men and women, but I wouldn't get too worried about a QTC until it gets above 500. So once you see a QTC above 500, that starts to be a risk for ventricular dysrhythmias.
Excellent. Thank you, Melanie. And the thing about these intervals, if you don't think about it, you won't think about it, which means you'll miss a QRS complex prolongation in a patient who might have overdosed on a tricyclic antidepressant, which is a sodium channel blocker, for example, which prolongs the QRS complex. So let's keep moving. So here is a beat. Here is the P wave. Here's the PR interval. Here is the QRS complex, and here is this elevated ST segment. The ST segment should be on the same area as should be on the same height as the baseline in between beats. In this case, you see this insidious convex upward ST segment. This, ladies and gentlemen, is the enemy. Let's compare it to a normal beat. Here is a normal beat. We see the P wave, the PR interval. The PR interval is from the beginning of the P wave to the beginning of the QRS. The PR segment is from the end of the P wave to the beginning of the QRS. Here's the QRS complex, the ST segment, and then here is the T wave. For future reference, you may know that the QRS complex is the sodium channel depolarization in the ventricles. The ST segment is the calcium channel depolarization, and the T wave, and well, let me finish. And the T wave is the potassium channel depolarization. Yes, Melanie.
Kevin has a question about the J wave. Could you just briefly talk about the J wave?
Sure. The J wave is a wave that occurs right at the end of the QRS complex, which occurs in patients that are hypothermic, that are very cold. There are two abnormal waves that can occur at the end of the QRS. One is a J wave, which looks like this, and the other is an Osborne wave, which looks, strangely enough, just like that. I'm sorry, the Osborne, I'm sorry, I misspoke. The Osborne wave and the J wave are the same thing. They look just like this. They are the same name, they are different names for the same phenomenon, which is a wave that occurs at the end of the QRS, the Osborne wave and the J wave. There is also an epsilon wave that occurs in the same place. You may remember that a delta wave in WPW occurs at the beginning of the QRS complex. But the epsilon wave occurs, well, let me finish. The epsilon wave occurs at the end of the QRS complex as seen in arrhythmogenic right ventricular dysplasia. Yes, Melanie?
Can you just point on that EKG where the J point is, or describe the J point really quickly?
Sure. The J point is the end of the QRS complex, and it's right there at the beginning of the ST segment, okay?
Good. And I'll just make maybe one comment too. Like there was a question about azithromycin, and just to kind of go back to this piece about QT intervals, like there's a lot of medications that prolong QTC. QTC, the C is just corrected for rate. Azithromycin is definitely one of them. I think that's why it got a lot of attention recently in COVID, and people were talking about prolonged QTs with azithromycin. There's a lot of other medications that prolong QT, including Zofran, a lot of psychiatric medicines. There's very many. So it's just, there's also something called a congenital prolonged QT, where some people just have a tendency towards that, that they're born with. So it's just something to be cognizant of. If somebody's already on a bunch of QT prolonging medications, they probably shouldn't be getting additional QT prolonging medications on top of that. Like, say you see somebody with a long QT, maybe Zofran is not the right medicine for them. And
so
maybe
Melanie,
I'll just make
Melanie,
one more.
why do we care about QT prolonging medications? What can happen?
The reason we care is because they're additive, and as we said, like the QT, as it lengthens and lengthens, you can imagine that QT segment becoming wider and wider. If it becomes like, once it gets above 500 milliseconds, you start to get a little worried about it degenerating into ventricular dysrhythmias, and that would be dangerous. So that's the danger of combining multiple QT prolonging medications. And then I might just mention one thing about the computer's interpretation. So when you get it 12 lead, oftentimes, depending on what device you're getting your 12 lead from, the computer will often give you an interpretation of it. The computer is quite good at calculating intervals, but it often will miscall arrhythmia. So like say you're getting a really kind of like shaky baseline, or the patient's moving, you don't have a nice clean baseline, it might really not pick up some small P's, and it tends to overcall things like maybe it's overcalling Afib because it doesn't see the P waves. You can't always trust it for that. You also can't always trust it for calling STEMIs, but it is pretty good at calculating intervals. So you can don't like trust the computer 100% to call a STEMI or to call it like Afib or a dysrhythmia, but you can trust its measurement of the intervals. It's quite good at that.
That's great. So we've gone through that. So now comparing these here.
For all the questions we're not getting to, we'll make sure that we give written answers to them after this.
I hope there were 1,000 questions. So ladies and gentlemen, please compare, excuse me, please compare these two things.
I think you might address this later, but can we talk a little bit about axes too? I think we might come on to that later in the talk.
We'll come to axis momentarily. So what I want to do is compare these two beats. Notice on this beat on the left that the ST segment, which is the calcium channel, is on the same level vertically as the baseline in between the beats. Notice on this beat to the right that the ST segment is considerably higher than the baseline in between the two beats. Here's the baseline. Notice this ST elevation, and notice the shape of this beat. It is convex upwards. This is the enemy. Convex upwards is an injury pattern, meaning infarction, meaning typically that a coronary artery of some sort has closed off for some reason and is now causing ischemia and injury to heart muscle. This is the enemy, ladies and gentlemen. Notice the convex upwards. Now, you are going to be cast 100 times, 200 times more in your career with 12 leads in front of you in which you are trying to decide whether this ST elevation, notice the baseline here and here, there's ST elevation here, there's ST elevation here, there's ST elevation here, and so on. Is this an infarction, or is this something else, such as early repolarization, which is a normal finding, very common, especially in young people with very strong hearts? The answer is that convex upwards, as we see here, is an injury pattern. Concave upwards may or may not be an injury pattern. And so the point is, you don't know for sure. And so you have to look for reciprocal changes. We'll show you one of those changes later to try to decide if this ST elevation is in fact a myocardial infarction, or is it early repolarization, which is a benign?
We just had another kind of good question come in. So what is the baseline? When you're looking at ST elevation, what is the baseline? Is it the T to P, or can you describe a little bit about like where you're measuring your elevation from?
Let me first, for the benefit of what you just said, here's the T wave, here's the P wave. And so this interval here is T to P. This is also known as the baseline. Those are the same thing. Baseline and T to P are the same thing. And in fact, the ST elevation is being compared to the baseline, which is the T to P, which is right here.
Yeah, good question. Good question.
Good stuff. I'll keep going. All right. Now, ladies and gentlemen, the electrocardiogram is set up. Remember, there are two types of things we read with electrocardiography. We read the rhythm strip, which is RRPISTTUA, RRPistua. Say that after me now. Ready? Go. RRPistua. I will never waste your time in an educational effort. Retrieval is the highest form of education, and this is true. you want to remember are pistule.
Oh, hey, Ray, I'm just going to give you 2 questions that I think you're going to get to, but just be explicit when you answer. Let's
Sure.
talk, when you get to some upcoming EKGs, just please be very specific about concave and convex upward ST elevations. And if you could also, yeah, just point those out if you don't mind. And then when we get to the bundle branch blocks, let's just be really explicit about the right and left bundles too.
You bet. We'll do all of that. And so, ladies and gentlemen, the 12 lead, remember, there is rhythm strip and there is 12 lead. The 12 lead is set up to be able to map the heart. There are 2 main arteries to the heart, one on the right, one on the left. The one on the right supplies the lower area of the heart called the inferior wall. Inferior, low, inferior, make sense? The left artery splits. It's a big artery, and half of it goes to the septum of the heart, and half of it goes to the lateral wall. It turns out, folks, that you can look at the electrocardiogram and be able to directly inspect the vessels that are involved. Namely, leads 2, 3, and F are positive under the heart, inferior to the heart. That is where the right coronary artery goes. Therefore, the right coronary artery goes to the inferior wall, also in 90% of cases to the AV node. So disturbances of the AV node, namely the PR interval, are associated with right coronary artery infarcts. The left coronary artery splits, and the left anterior descending goes to the front of the heart, so leads V1, V2, V3, V4, and I would add AVR are positive in that area in the anterior wall. Leads 1, L, and V6 are positive lateral to the heart. Beside the heart, there's only one lateral, which is left lateral. Yes, Melanie.
While we're talking about this, I think there's a few questions about looking at these 12 leads and what part of the heart they cover. I would say that somebody asked about lead V5. Yeah, I think you consider V5, because it's quite close to V6, like that could also be considered a lateral lead.
Yes.
And then, Ray, we've got a quick question about the septal leads, if you don't mind just pointing them out really quick.
If you take the heart and turn it this way, and you have V1 here and V2 here, they sit over the septum. And then V3 and V4 sit more on the anterolateral part. And thus V1 and V2 are generally considered the septal leads. Now, focus, listen to what I'm saying. In my clinical experience, I have not seen much use in separating out septal versus anterior. Therefore, V1, V2, V3, and V4 are the family of anterior leads. You can call it septal if you want, but it doesn't matter. Now, the reason septal, well, let me finish, Madeline. The reason septal is put out there is because in the septum, the bundle branches run. And so if you have a septal infarct, it may be more likely that you may have a disturbance of the bundle branches. I will show you one of those in just a moment. Melanie?
I don't want to go over time, but maybe somebody asked about 15 leads and right-sided leads. We might just mention a quick 2-liner about what those are and why you might want them.
It turns out that they're not just 12 leads. You can also put, which, as you know, are on the limbs and on the front of the chest. But the heart is an electrical organ. You can look at it from the butt if you wanted to. You can look at it from all kinds of different ways, including on the back. You can look at it from the right side of the chest. And it turns out that there is additional information to be found. For example, if the way lateral part of the circumflex artery clogs up and actually causes an infarction on the back of the heart, you could actually move, for example, leads V4, V5, and V6 and put them on the scapula, on the shoulder blade, and you could see ST elevation there in the setting of a posterior MI. And I will show you one of those in just a moment. Good question, Melanie. So let's practice. All right, now, ladies and gentlemen, I had the pleasure 3 times in my life back in the 1980s to go hang out with Barney Marriott, H.J.L. Marriott, arguably one of the great electrocardiographers in the history of the world. He wrote Marriott's Practical Interpretation of Electrocardiograms. And I got to go hang out with him at a conference 3 different times, sitting at the foot of the master, reading 1,000 electrocardiograms every time. Ladies and gentlemen, the way you learn to read a cardiogram is to watch somebody who knows how to read them read the electrocardiogram. And so I know a little bit about it, as does Melanie. So why don't we read this electrocardiogram together? We start with rate and rhythm. Well, let's see here. This QRS complex falls about on this beat. There are 300 of these big boxes per minute because there are 5 per second. So if there are 5 per second times 60 seconds in a minute, there are 300 boxes, 300 big boxes per minute. So if a beat fell on every big box, that'd be a rate of 300. If it fell on every other box, that'd be 150. Every third is 100, 75, 60, 50, 43, 37, 33, 30. So what do we see here? A box falls here, a beat falls on this box, 300, 150, 100. It's faster than 75 and slower than 100, and indeed the machine reads it as 85. So the rate is normal. The rhythm is perfectly clock regular. There seems to be a P wave for every QRS. The PR interval is prolonged. It's greater than 1 big box, and it seems to be stable. The QRS complex seems to be narrow. The ST segment is altered. Nothing to say really about the T wave. The T wave is inverted here, and there's no U wave present. So what do we see? The rate is normal, the rhythm is regular, and there's a P wave in front of every QRS. This is a normal sinus rhythm. There is a first-degree AV block, prolongation of the PR interval. And then what else do we see? We see ST elevation in 2, 3, and AVF. Those are the inferior leads. That is the right coronary artery. In that setting, when we see ST depression on leads on the other side of the heart, that is called reciprocal depression. So we see reciprocal depression here and even some over here. But, ladies and gentlemen, in the setting of an acute inferior wall myocardial infarction, look at V2 next. Did you hear me? Look at V2 next. In this one setting, ST depression in V2, along with an inferior MI, is an acute infero-posterior myocardial infarction. And I would add to that, if you took leads V4, 5, 6 and put them over the scapula, you would see ST elevation. Or if you took this electrocardiogram, this ECG, and turned it over like this and looked at the light through it, you would see in V2 that there's ST elevation. You follow what I'm saying? So you can actually turn it upside down and create your own posterior thoracic leads. Melanie, any comment?
I think some people are getting a little disrupted by the questions, like interspersing your lecture. So I'm going to try not to interrupt you. But yeah, somebody just mentioned, kind of be a little. I don't want to interrupt because I don't want to make you, kind of like make this disjointed. Yeah, just maybe clarify a little bit about what you mean by reciprocal change, though.
All right. Remember, ECG leads that are sitting over the site of an infarction where the muscle is being damaged or killed show ST elevation. ECG leads on the other side of the heart from the infarction show reciprocal depression. Repeat that after me. This is called retrieval. It is the highest form of memory recall. ECG leads, say it together with me, ECG leads that are over the site of the infarction show ST elevation. ECG leads that are on the other side of the heart from the infarction show reciprocal depression. It happens in groups. There are 3 groups: the inferior group, right coronary, the lateral group, the circumflex artery, and the anterior group. And thus, as you see in this setting, in this particular electrocardiogram, you see ST elevation in the inferior group of leads. Thus, this ST depression that you see in the lateral leads on the other side of the heart is reciprocal depression. Let me bring home one more time that in the unique setting of an acute inferior wall MI, look next at V2. And if you see ST depression in V2 in the setting of an acute inferior wall MI, that is an infero posterior. That is that in that one setting. I know I gave you a complicated cardiogram to start off with. Let's look at some other. So what do we see here? All right, so what do we see? Yes,
Can I ask
Melanie.
one question? I know we talked about ST elevation. What if you only see ST depressions but not ST elevations? What is that?
It can be several things. For example, it could be the drug digitalis. It could be. It could be ischemia in the absence of infarction, which means the muscle is threatened but not dead. It also could be left ventricular hypertrophy, which we will show a slide of in just a moment. So let's hustle. As best I'm watching my clock here, we have about 20 minutes, Melanie, so we probably need to put on the fast lane here.
Okay.
So what do we see here on this one? We see the rate is normal, the rhythm is regular, there's a P wave before every QRS. There is ST elevation in 1 with ST elevation in 6. These are lateral leads. So this is an acute lateral wall infarction. We see also some ST elevation in lead 2, and also in lead AVF. So this is an inferolateral. And we also see, since we see an inferior infarction, we look at V2 next, and there's ST depression. So this is an acute posterolateral with inferior wall infarction as well. Let's look at another one. What do we see? The rate is normal, the rhythm is regular, it's 92. We see massive ST elevation in the inferior leads with ST depression in V2. So this is an acute infero-posterior. We see depression here, but in this lateral lead and in this lateral lead, we see elevation. So this is an acute infero-posterolateral. Don't let those terms confuse you at all. This is simply what part of the wall is involved with the infarction. Inferior wall is involved, posterior wall is involved, and the lateral wall is involved as well. Let's look at this one. So what do we see? Well, let's not go through rate and rhythm now. What do we see? We see that this is ST elevation anteriorly, and there may be some what would be reciprocal depression here, but there's also ST elevation laterally here. There should be a little R wave here, a larger R wave here, and a bigger R wave here. That is called R wave progression. We don't see the R wave progression in these leads. So this is an acute anterior wall infarction with lateral components. So this is an acute anterolateral myocardial infarction. Let's keep rolling. So what do we see here? We won't do rate and rhythm. We see that there is some lateral wall elevation, especially you see it in AVL. So there's a lateral wall myocardial infarction with what must be reciprocal changes here. And then we also see ST elevation in V2, in V3. Notice there's not an R wave here, not an R wave here, not an R wave here. This is a sign of damage to the acute damage to the anterior wall. So this is an acute anterolateral myocardial infarction.
I don't want to interrupt you, but again, could you just point out the J points and like the concave versus convex ST segments?
Yes, and let me take this as a point. Amal Mattu, as a mutual friend of mine and Melanie's, is one of the great electrocardiographers in emergency medicine in the world. He's at University of Baltimore, and he puts his lectures out online. These are like 15-minute talks. They are bulleted, and he is a PowerPoint master. And so I encourage you to look up Amal Mattu. I'll give you his name at the end of the talk. Amal points out that you can't always depend on convex upwards ST segment elevation. Indeed, this elevation here is straight. And Amal Mattu points out the fact that straight ST elevation is one of the strongest coinciders with infarction. The J point, Melanie, as you questioned about, is the end of the QRS, as we see in V5 here, and the ST segment begins and is then lost in the T wave. Here is the J point here.
It's kind of almost like what they sometimes call tombstone ST elevations. Like those are kind of approximating tombstone ST elevations, where it's really convex upward. You can imagine looks very much like a tombstone.
And so that is a name that is used, and you should be aware of that if you're not already, which is the setting of massive ST segment elevation. The term has been used over the years, tombstone elevation. So just be aware that that's out there. All right, so what do we see here? All right, this is fast. We see a beat that falls here, 350 to 100, so the rate is 109. The rhythm is regular. We see ST depression inferiorly, ST elevation laterally, and then we see ST elevation anteriorly. So this is an acute anterolateral myocardial infarction. This is the J point. Notice we don't see really any change in the ST segment in V5 here, nor in V6. We do see an inverted T wave in V6 here. So this is an acute anterolateral myocardial infarction. Notice again, there should be a little R wave here, a bigger R wave here, and a bigger R wave here, and even larger here. The loss of this R wave can be indicative of acute damage to the myocardium. All right, so what do we see here? This is, let's see, 350, 175. The rate is actually fairly slow. The rhythm is regular. There's a P wave for every QRS. But what do we see? We see this ST segment elevation anteriorly, but we don't see really any reciprocal change. What is this? This is what is called as benign early repolarization, or early repol. The J point, which is the end of the QRS, the J point is elevated. You have a concave upwards ST segment. The T wave is kind of elevated, and you don't see reciprocal changes. This is probably benign early repol. Ladies and gentlemen, be careful. About the time that you think you've got a patient with benign early repol, in fact, may be a patient having a heart attack, having an MI, and in fact, they're just not showing reciprocal changes. Listen to me. The absence of reciprocal changes does not mean that the patient is not having a heart attack. You say, well, this is really hard. I know. This is why it's a lifetime of study. Electrocardiography is a lifetime of study. I've been studying these things for almost a half century, and I'm just finally getting kind of good at it. So welcome to the world. And so what do we see here? We see the setting of what we call a benign early repol in the previous cardiogram. Notice there are no reciprocal changes. And in the setting of this ST segment elevation here with reciprocal changes inferiorly here. All right, so what do we see here? We see that we have a patient with we see a patient with ST elevation laterally, but then we see these funny lines here. And then we see a patient over here with ST elevation here. What are we talking about? Notice that there is the PR interval, which starts at the beginning of the P wave to the beginning of the QRS complex. That is the PR interval. The PR segment is from the end of the P wave to the beginning of the QRS complex. Notice here that here is the PR segment, and we've drawn a line here. And then here we've looked at the J point here, the end of the QRS complex. And then here we've looked at the height of the T wave. There is an interval here and an interval here. Let's talk about this. This is acute pericarditis. So you will commonly find patients who are having some funky chest pain or something else, and you do a cardiogram, and you see ST elevation, but you don't see reciprocal depression. But then you look at one that has ST elevation everywhere. They've got it laterally, they've got it inferiorly, and they've got it anteriorly, but they have PR segment depression. It turns out that you can pick up people who have inflammation of the lining of their heart, their pericardium, which is very important in this COVID area because pericarditis and myocarditis are associated with COVID infections. You can go to what's called lifeinthefastlane.com, lifeinthefastlane.com, and they will show you how to tell the difference between the narrow PR segment to J point, a very narrow line here, versus J point to T wave, versus you see here a wide area of PR segment to J point and J point to T wave. When the interval between the J point and the T wave, it approaches the width from the J point to the top of the T wave. Make sure I said that correct. From the PR segment to the J point, approaches the same width from the J point to the top of the T wave. That is acute pericarditis, and you'll see it once in a while. All right, we're going to keep running because we are going to be running out of time pretty soon. I got to stop in about 6 or 8 minutes. I just wanted to show you this particular one. Notice that the rhythm is regularly irregular, Each beat is followed by a wide complex that does not have a P wave in it. This happens to be a 12 lead of ventricular bigeminy. Now notice that we don't see ST segment changes on the conducted beats. We do see some ST segment elevation here, very slight in V3, but no question of reciprocal change. So the question is, what is causing this ventricular bigeminy in this case? Is it ischemia, or is it someone who's having an arrhythmia for another cause? So what do you see here? Ladies and gentlemen, look at this 12 lead, and I want you to give me one word right now. One word. Slow. You say, well, duh, I know that. Did you? Would you have seen that on a monitor out in the field, in the ditch, in the dark, in the blowing rain at 4 o'clock in the morning? Because when you see this, what is the first thing that you look at? You look to see if they have a radial pulse and are they breathing? Because as you may know, the radial pulse appears at a systolic pressure of 80, the femoral at 70, and the carotid at 60. And so quickly, if you see, and blood pressure equals cardiac output times peripheral vascular resistance. Cardiac output equals pulse rate times stroke volume. If you drop the pulse rate, which in this case is due to a high-grade AV block from this atrial flutter, it could be a poisoning with cardiac medications, you immediately want to know, does this patient have a pressure or not? Put on the pacing pads, the external pacing pads quickly. That would be something that as a medical director, I would immediately review this chart. What do you see here? Well, you see that the rate is quite slow. And V1 is the lead that gives you the best look because V1 sits right over the right atrium as what's happening with conduction. Notice that every other beat is dropped, or maybe even more often than that. This beat is probably dropped. What is happening here is complete AV dissociation. This is a 3rd degree AV block. Notice that the complex is wide. This is actually a primary ventricular rhythm, and there's complete AV block. There's a bradycardia present. Put on the pacing pads. Ladies and gentlemen, if you see complete variability of a PR interval in the setting of bradycardia, be careful. Put the pacing pads on that patient. Now let's get into bundle branch block. What do we see here? We see that the rhythm is fast, that the rate is fast, the rhythm is regular. we see a wide complex, and we see a big upright fat QRS complex in V6 with ST depression and T wave inversion. We also see S waves across the precordium. This is left bundle branch block. This means one of the two main bundles is blocked. And we have typically said in the past that in the setting of a left bundle branch block, you cannot pick up an acute anterior wall MI. Now, please look at this left bundle branch block. Notice that in V6, the ST segment is depressed and the T wave is inverted. And notice that you have S waves across the precordium. Listen to me. This is what a normal left bundle branch block looks like. When you see a left bundle branch block, you look to see if it looks like a normal left bundle branch block. There are criteria that occur, named by a guy named Scarbosa.
A woman.
That happened to be a gal, who said, if you see ST elevation in V6, that shouldn't be there. That's a heart attack. Or if you see enormous ST elevation in the setting of the left bundle in V1, V2, V3, that shouldn't be there. That's a heart attack. That is also the softest criteria. Or in V1, V2, V3, if you see ST depression, that shouldn't be there. That's a heart attack. These are called the Scarbosa criteria, and you should be aware of those. And here is an example of a 12 lead that is a left bundle branch block, but notice in V6, there's enormous ST elevation in V6 and V5. That is a heart attack in the setting of a left bundle. And you see huge ST elevation in V2 and especially V3. That is a heart attack. That shouldn't be there in the setting of a left bundle.
I think we might answer more in the questions after, but the Scarbosa criteria apply to paced rhythms as well. So that's how you can sort of have some tips about calling STEMIs in a paced rhythm. We'll answer that after.
And let me say that we're going to have to stop in about 2 minutes. And so what we'll do is that if enough of the crowd asks us back to come back and give another lecture, Melanie, you and I'll come back and we'll talk about that and SVT and Vtach. So here is a patient who has left axis deviation, -5 degrees, and that you see they have ST depression and T wave inversion. This is left ventricular hypertrophy. They have a deep S wave and a huge R wave, which if you added them together is 35 millimeters or more. In that setting, this is called left ventricular hypertrophy with repolarization abnormality. There are also things that look like a right bundle branch block that in fact are not. This is Brugada. Melanie, you want to tell them what Brugada is?
Oh, you keep going. I'm just scrolling the questions for anything that we can quickly interject.
All right, so Brugada is a sodium channelopathy, which is said to result as much as 5% of the ventricular fibrillation cardiac arrests in the world. But it's not a right bundle, but it looks like a right bundle, doesn't it? All right, and in this setting here, we have a patient with up, down, down, -45 or more is a left anterior hemiblock, and with an RSR primed anteriorly, this is a right bundle branch block. Left anterior hemiblock plus right bundle branch block is a bifascicular block. And since there is ST segment elevation here, this is with an acute anterior wall myocardial infarction. Melanie, you want to cover this one for them?
You keep going. We're kind of running short on.
Fine. All right. Notice that there's a rhythm disturbance. We see bradycardia on this part of the 12 lead. This is all part of the same patient. And notice that there's a P wave here, then drop, P wave here, then drop, and P wave here and drop with a wide complex. Folks, this is a Mobitz 2. Notice that on the conducted beats, the PR interval is normal and it doesn't change. But on every other beat is dropped. This is Mobitz 2. And ladies and gentlemen, this period in between the beats, in between these P waves, this flat line, what do we call flat lines? Asystole. This is why Mobitz 2 is so dangerous, because after these P waves, both bundles have blocked. There's already a bundle branch block present. And in the setting of every other beat, the other bundle blocks. This is a period of asystole. This patient could die in front of you because of loss of conduction. But notice that this patient gets the conduction back in this half of the cardiogram. What a strange cardiogram. And what if you had not seen this part? You would have missed the fact that this patient could be about to die. This is Mobitz 2, converting to a sinus rhythm. Put on the pacing pads.
I don't want to interrupt, but again, looking at some of the questions we didn't get to, we'll probably definitely have to come back again if you guys want. And I highly recommend that Life in the Fast Lane website. If you take a moment and Google Life in the Fast Lane, all of these questions, and I think the repetition to me is like the key to learning EKGs, just looking at pattern recognition, seeing the same EKG over and over and over. And the Life in the Fast Lane website is really great.
So let's do this last one. This will be our last cardiogram. I'm sorry I had to skip a couple, but we're running out of time. So what do we see? We see that I got this tracing yesterday that came in. We see that there's ST elevation here with what could be some reciprocal depression. My question to you is this an acute anterior wall MI, or is this a patient with early repolarization? The machine thinks possibly early repolarization, but be careful. It could be an MI. So to conclude, Melanie, let's make some last comments. Could you please?
Sure. So I think you've done a great job about talking about a lot of the things that we care about in interpreting both rhythms and 12 leads. I think to me, again, like I said, just the real way to learn them is like seeing a million representations of the same thing. So you just have to see a bunch of STEMIs. You got to see a bunch of right bundles. I think maybe in the future we could talk more about some of the things we didn't cover, like maybe some blocks and any of the other things that we didn't get to in the question. This is a picture of Dr. Amal Matua that you've got up here on the screen. His website, I belong to it. It used to be free, and you can probably find a lot of his old lectures on YouTube, but he now has a subscription that we'll have a link to, and I think it's like $20 a month, $20 a year, and he does a monthly EKG talk, or I think he does a weekly EKG talk, and it's like for $20 a year. It's really great.
Yeah, and the reason I bring this up, Melanie, is what Amal has said is that you get so much information from an electrocardiogram and a rhythm strip.
And one more thing.
The patient's rate, the patient's rhythm, the physiological aspects, not to mention infarction, block, and so forth.
The other thing that Dr. Matou talks a lot about is serial EKGs. So, sometimes if a patient doesn't look so great and their first EKG looks pretty reassuring, get another one. You can see the ST elevations happening right in front of you. The other thing that he sometimes mentions, like you can actually see the reciprocal depressions appear before the ST elevation. So maybe you catch somebody right at the beginning of their inferior STEMI, you get your first 12 lead and they don't have ST elevations inferiorly, but you might see some reciprocal ST depressions in the lateral leads. And then 15 minutes later, you get another EKG. Now they're starting to elevate in the inferior leads. Then you get another one, and now they're really elevated. So, Dr. Matou always says an EKG is just ink and a piece of paper. If you have any question, just get another one, and you can see dynamic changes happening right in front of you.
And so since our time has now run out, ECG interpretation skills have to be maintained. These are the ECGs I've looked at in the last couple of days alone that I get. So it's something that you have to do, and you have to promise yourself that it will be a lifetime of continual study. And that's it. Cindy, take it away.
Yeah, if you could go to the next slide for me, Dr. Fowler. I want to thank you again, Dr. Fowler and Dr. Lippman, and thank you again, Wheeled Coach, for sponsoring today's webinar. This concludes our webinar. May you, your colleagues, your community, and your family remain healthy and stay safe.